Good morning everyone, I am Dr. Tejaswini from the Department of Oral and Maxillofacial Surgery. So today I will be discussing about salivary gland disorders. Salivary gland disorders include conditions which present with inflammatory, bacterial, viral or neoplastic etiologies. The presentation can be acute, chronic or recurrent based on the time of onset of symptoms. Benign and malignant tumors can also occur in the salivary glands, which usually present as solitary neck masses. So what is the role of salivary gland? The main function of the salivary gland is the production of saliva, which helps in supporting your oral and overall health. Saliva moistens the food and makes it easier for us to swallow, and it also contains an enzyme called salivary amylase, where the digestion first starts in the mouth itself. And it helps in lubrication of the mouth, thereby keeping the mouth clean, and also helps to reduce the risk of cavities and gum diseases. It also helps to maintain the pH balance in your mouth. So when you analyze the biochemistry of saliva, it is a complex mixture of fluid, electrolytes, enzymes and macromolecules that function together to perform several functions like lubrication to aid in swallowing, digestion of starches with the enzyme salivary amylase, modulation of taste and protection against dental caries and defense against different pathogens. So we have two groups of salivary glands. One is your major salivary glands and the minor salivary glands. So the major salivary glands are your parotid gland, submandibular gland and sublingual gland, and the minor salivary glands are numerous and which are distributed over the mucosa of lips, tongue, oral cavity and pharynx. So this is a pictorial representation of your salivary gland. This is a parotid gland, submandibular gland and sublingual gland, the secretions of which are carried into the oral cavity by means of a duct. So the duct transmitting the secretions of parotid gland is called your Stenson's duct, and the submandibular gland secretions are transmitted to your Wharton's duct, which is located beneath the base of the tongue. So the group of disorders affecting the salivary gland can be classified into four broader categories. One is your inflammatory disorders, which includes acute suppurative siluritis, and the predisposing factors are diabetes mellitus, hypothyroidism, renal failure and Sjogren's syndrome. And also the use of certain medications by the patients, especially the medications which have anticholinergic properties, can also reduce the salivary flow. And silolithiasis, which is nothing but the obstruction of salivary flow, and duct strictures can also cause acute suppurative episode of your salivary glands. The most common bacteria associated with the siluritis is Staphylococcus aureus, and studies have shown the involvement of streptococcal species and Haemophilus influenzae as the other bacteria. So clinically, when the patient presents to us with acute suppurative siluritis, he can give a history of pain and swelling of the affected gland, and when you examine the patient clinically, he may reveal induration, edema and extreme localized tenderness at the opening of a concerned salivary gland duct, and the massage of the gland may express pus from the respective intraoral orifice, and the pus thus extracted should be sent to culture for direct antibiotic therapy. And the management of this condition is to treat the infection and reverse the symptoms, and also reverse the underlying medical condition and predisposing factors. So the first basic step is the stimulation of salivary flow by application of warm compresses, administration of siloglogs like your lemon drops and vitamin C lozenges, hydration, salivary gland massage and oral hygiene. And you can start first with your empirical antibiotic therapy, that is amoxicillin clavulanate, and later when the pus is sent for culture, you can also go for culture directed therapy. And in rare cases where the acute suppurative siluritis, it can lead to an abscess formation necessitating the surgical drainage. So if the onset of symptoms is of short duration, it is called acute siluritis. However, if the symptoms are prolonged more than 10 to 15 days or a recurrent episode, it is called as chronic siluritis. So the chronic siluritis is characterized by repeated episodes of pain and inflammation caused by decreased salivary flow and salivary stasis. Most commonly, the parotid gland is affected, either due to the salivary gland duct obstruction from stones, strictures, scarring or foreign bodies, or extrinsic compression by an ongoing tumor. And when there is a recurrent inflammatory reaction, there is a progressive acinar destruction leading to fibrous replacement and silectasis of the salivary gland. So clinically, the patient presents to us with a recurrent low-grade swelling and tenderness of the affected gland. Physical examination will reveal enlargement of the gland in the initial stages, but as the dissection is proceeding, the size of the gland will decrease in later stages. And massaging the gland toward the orifice does not produce any visible saliva, and if no cause is found, treatment is conservative and it is aimed to relieve the symptoms and should also consist of silogogues, massage, hydration and anti-inflammatory medications. However, in severe cases, the excision of the gland is safe and effective with low incidence of xerostomia. This is a condition which is usually seen in children, that is the recurrent parotitis of childhood. It is an inflammatory condition of the parotid gland and is characterized by recurrent episodes of swelling and pain. The cause of the disorders is unknown, and children typically present with recurrent episodes of acute or subacute parotid gland swelling with fever, malaise and pain. So the swelling is usually unilateral, but both sides can be affected, and episodes may last for days to weeks and occur every few months. So the treatment main is supportive care with adequate hydration and gland massage, warm compresses, silogogues and antibiotics. The condition usually is resolving spontaneously with puberty, and surgery is rarely advised. So now we are done with the inflammatory conditions. Let's see what all come under viral salivary gland disorders. The main is your mumps. Mumps is caused by paramyxovirus. It is the most common cause of non-suppurative acute silentinitis. 85% of the cases are seen in children younger than 15 years of age, and the disease is highly contagious and spreads by airborne droplets from saliva, nasal secretions and urinary secretions. And this condition is characterized by a local pain and edema, as well as otalgia, that is the pain in the ear, and trismus, that is reduced mouth opening. And most cases are bilateral, though it is commonly beginning in the one side. So clinically, the child presents to you with this condition. The diagnosis is confirmed through the viral serology, and treatment involves suppurative measures like your hydration, oral hygiene and pain control. The edema associated with this condition typically resolves over several weeks, and vaccination, which is usually completed by the age of 4 to 6 years, is very effective in preventing this viral infection of the salivary glands. The other most common viral infection is your human immunodeficiency virus associated salivary gland disorder, and it is seen as a lymphoepitheliosis, which may be the initial manifestation of the disease, and it presents as a gradual non-tender enlargement of one or more of the major salivary glands, and the patient may have decreased salivary function resulting in xerostomia, which can mimic Sjogren's syndrome. And the management of the case involves around antiretroviral therapy, oral hygiene and silogogues. The obstructive salivary gland disorders, here the gland is affected because there is a blockage in the flow of the salivary secretions. The first condition is the silolithiasis, which is nothing but the stone formation. So silolithiasis is caused by the formation of stones in the ductal system. The submandibular gland is frequently affected apart from your parotid gland because of the tortuous nature of the duct and the composition of the saliva in the submandibular gland, which is having high mineral content. So the stones are composed of precipitated salts and proteins, and predominantly calcium carbonate is seen. So studies have shown three prerequisites which are associated with silolithiasis. First is a nidus formation, which is nothing but a complex glycoprotein gel, and this nidus is probably caused by a subclinical retrograde duct infection that initiates changes in the saliva's mucoid molecule. The second is salivary stasis, that is pooling of the saliva, and the third element is the precipitation of salts into glycoprotein matrix with the continued mineral deposition, calcium carbonate precipitate, and clinically apparent, this becomes clinically apparent as your salivary stones or silolithiasis. So how do the patient present to us? The patients typically present with a postprandial salivary pain and swelling, that is the patient will have pain after taking food. They may have history of recurrence of acute suppurative silentinitis, and on bimanual examination, on bimanual palpation, you can feel the stone. Ultrasonography and non-contrast CT can also be indicated to detect the stone. So management of silolithiasis. The initial management aims at treating any acute infection followed by surgical removal of the stone. The surgical approach depends upon the location of the stone, and submandibular gland stones are usually excised intraorally under local anesthesia. However, if it is involving the parotid gland, wide excision has to be done. An alternative for the open surgical excision is your siloendoscopy, wherein a small rigid endoscope is passed and the stone is retrieved. So Yamassoba and all, they have highlighted two crucial etiological factors in mucosis, that is traumatism and obstruction of salivary gland ducts. The retention mucosals are formed by dilation of the duct secondary to its obstruction and is caused by a silolith or dense mucosa. The majority of the retention cysts can develop in the ducts of major salivary glands. So the next disorder is mucosal. Mucosal involves mucin accumulation causing limited swelling. So typically there are two types of mucosals. One is your extravasation type and the other is your retention type. Extravasation mucosal results from a broken salivary gland duct and the consequent spillage of the salivary contents into the soft tissues around the gland. Whereas your retention mucosal appears due to a decrease or absence of glandular secretion, which is caused by a blockage in the salivary gland duct. And when this mucosal is typically seen in the floor of the mouth with a bluish swelling, it is called as ranula. And its swelling typically appears blue in color because of the venous congestion or vascular congestion and tissue cyanosis. So this extravasation mucosals appear frequently on the lower lip, whereas the retention mucosals appear typically in any other location of the oral cavity. So the treatment and the management of mucosals and retention mucosals is, first is your conservative management, elimination of any traumatic or etiological factor, surgical excision, marsupialization, carbon dioxide laser ablation and cryotherapy. Coming to the autoimmune disorders affecting the salivary gland, Sjogren's syndrome is a multi-system autoimmune disease which is affecting mostly women, and it is causing the hypofunction of your salivary glands and your lacrimal glands. So there is a systemic involvement affecting causing the pulmonary disease, vasculitis, lymphadenopathy, Raynaud's phenomena, autoimmune thyroiditis, hepatosplenomegaly, achlorhydria, leukopenia and thrombocytopenia. So typically the patient presents to us with a dry mouth, which is also called as xerostomia, and blepharitis, that is inflammation of the eyelid margin, as you can see in this picture, because of the decrease in lacrimal gland secretion. So American College of Rheumatology has established certain criteria for the patient to be classified under Sjogren's syndrome. So the patient has to fulfill at least two of the following criteria, that is positive serum anti-SSI or anti-SSB antibodies, labile salivary gland biopsy confirming the Sjogren's syndrome, and keratoconjunctivitis sicca with an ocular staining score of 3 or higher. So the patient present to Sjogren's syndrome, the patient presents to us with a marked salivary volume reduction, which is clinically manifested as burning sensation, difficulty with swallowing dry foods, and loss of taste, and mucosal pain from the pressure created by the removable dentures, and the tongue is often seen giving a cobblestone appearance or cracked appearance, and overlying fungal infection by candida can also be a problem, and there can also be rampant dental caries which is resultant from the hyposalivation. The next condition is sialoadenosis. Sialoadenosis or silosis is characterized by asymptomatic but bilateral enlargement of your salivary glands involving the parotid glands mostly and rarely the submandibular glands, where there is no detectable underlying pathology. The swellings are persistent and do not fluctuate in size and usually are symmetric, and when palpated are normal in tone. Most commonly they are seen in conditions associated with patients with alcoholism, diabetes mellitus, malnutrition and idiopathically. So the etiology has found to be the autonomic neuropathy manifesting itself as a demyelinating polyneuropathy. The neuropathy results in excessive salivary SNR protein synthesis or a failure of its adequate secretion, altogether manifesting as a asymptomatic enlargement of your salivary glands. The next condition commonly seen is your anesthesia mumps. It is seen in association with administration of general anesthesia during an intra-anesthetic or post-anesthetic period, and the patient presents with straining, coughing, sneezing of the patient during a difficult anesthetic procedure or post-anesthetic period. They serve to increase the positive pressure in the oral cavity, and simultaneously adjunctive agents such as your succinylcholine, which cause a loss of muscle tone around the Stenson's duct orifice, they facilitate the retrograde passage of air into the parotid gland by intubation. So this results in bilateral or unilateral parotid swelling, which will usually be noted in the recovery room, often during extubation. The swellings are transient in nature and subside within 1 to 5 days. The other condition is a silectasis, which is the dilatation of the duct within the salivary glands. It is most commonly seen in the parotid gland and it is associated with ascending infections and gland destruction. Clinically, the patient presents to us with isolated diffuse swelling of the affected salivary gland. So to categorize, the following table gives us a brief idea of the different conditions as associated to the salivary gland disorders. So first is your acute suppurative salinitis, the etiology being bacterial infection. Clinically, there will be a sudden onset of pain and swelling, and the diagnosis is confirmed by swollen, indurated tender gland and pus discharge from the duct. And the treatment, antibiotics, gland massage, hydration, Silogox, warm compress and hygiene. And a chronic and recurrent case of salinitis where the obstruction is the key factor, and there will be repeated episodes of pain and swelling, often with meals, and there is a history of recurrent infections, and this is clinically confirmed by swollen or firm gland, and they may appear normal on examination or on imaging. And the treatment again is conservative, that is hydration, gland massage, siloendoscopy or open surgery. The next condition is your neoplasm, which can be a benign or a malignant neoplasm. Occasionally they can be presenting as painless, firm or slow growing mass, and the diagnosis is confirmed by imaging, that is your computed tomography or MRI imaging or FNAC, and the treatment is surgical removal of the gland or the tumor. And the next condition is your recurrent parotitis of your childhood, where the etiology is unknown. The patient presents to us with repeated episodes of pain and swelling of the parotid gland, especially seen in children, and the diagnosis is confirmed by your clinical history, examination and imaging findings, and the treatment is antibiotics administration, gland massage, hydration and siloendoscopy. The next is your viral infection, which is most commonly seen viral infection is your mumps or HIV virus affected salivary gland disorder. There is a swelling often involving the bilateral salivary glands, and the diagnosis is confirmed by viral serology, and the treatment is aimed at supportive care, antiretroviral therapy for HIV induced viral infection. So how do you evaluate a patient when you suspect a salivary gland disorder? The case of a suspected salivary gland inflammation, first take a brief patient history and perform physical examination. If it is a localized disease, it could be either acute phase of the disease or recurrent or chronic phase of the disease. That is, in acute phase, you will have pain, swelling and fever, which could be either due to a virus or your bacterial infection. If it is a viral infection, you confirm it by viral serology, and the treatment is aimed at observation and supportive care. Whereas in your bacterial infection, you can go for a needle aspiration and then sending the exudate or transudate for your culture and sensitivity. First you start the patient on empirical antibiotic, then you go for specific antibiotics and Silogox and supportive care. And if it is a case of recurrent or chronic salinitis, which is confirmed by recurrent swelling and gland firmness, first is evaluate the duct by either radiography, silography or computed tomography or siloendoscopy. If the reason is found to be obstructive, that is obstructive chronic salinitis, either because of the strictures or siloliths or silectasia, dilatation of the duct, silorhodoplasty, gland excision and antibiotics are to be administered. And if it is a non-obstructive etiology, salivary gland biopsy can be done, and always assess the patient for rheumatoid serology and salivary analysis and needle biopsy. And if the patient is also giving a history and the physical examination confirms the systemic findings like fever, arthralgia and Zika, it is mostly suggestive of a Sjogren syndrome, fungal disease, lymphoma and myobacterial disease. So let's have a look at the different diagnostic aids. First is your silography. Silography is nothing but the imaging of the salivary glands, most commonly advocated for your parotid gland. So the salivary ducts are conventionally examined under fluoroscopy with high sensitivity through cross-sectional imaging with either CT or MRI. So indications of silography: when there is a repeated pain and swelling where ultrasound does not yield any usual findings, or when you are suspecting a case of silolithiasis, suspected silectasis. However, this procedure is contraindicated in pregnancy and patients who are allergic to iodine contrast media, and when there is an acute phase of silinitis. So this is how a silograph will be seen. So this ductal pattern confirms the disease. The next diagnostic aid and the therapeutic aid is just siloendoscopy, which is an endoscopic technique to diagnose and treat the salivary gland problems. A specialized very narrow endoscope called a microendoscope provides lighted view of the inside of the gland. So these microendoscopes range from diameter of 0.8 to 1.6 millimeters in width, and this is fitted with a light and camera and tools, and tiny basket probes and small graspers can extract very small siloliths or just small stones. So this is how the siloendoscopy procedure is done. The first diagram is showing the different probes, the second picture is showing the intraoperative procedure, and the last picture is showing a basket retriever where the salivary gland stone is extracted. And B picture, the other picture is showing the cannulation of the salivary gland duct. Thank you.